All right, ladies and gentlemen, welcome back for episode 35. So the last couple episodes you were just stuck with me, and now we've got Kerry, a much easier on the eyes, prettier face to look at. So pay attention to her, and we'll get started. But I think we're going to talk about some of the myths that are surrounding female hormone replacement, and particularly bioidentical replacement with estradiol, with micronized progesterone. Carrie and I had gone to a conference, was 2 weeks,
Hmm.
2 weekends ago.
Coordinator.
Yeah, in Coronado, with one of our favorite lecturers. And it's funny because he's like, oh, the studies say that estrogen causes this. He goes, oh, that's great because I don't prescribe estrogen. I don't prescribe estrogen. And they're like, well, people, and he's like, they get all nervous. And he's like, well, no, because I prescribe estradiol. And so the estrogen studies were based on conjugated equine estrogen. You can't compare the two. And if you do, then you've got a problem. We really can't continue this discussion. So conjugated equine estrogens are not the same as estradiol. The studies that show that conjugated equine estrogens increase risk for blood clots are there. You cannot extrapolate that information and say that oral estradiol increases your risk of blood clot. There is no study that shows that it does. The progestins are all the fake stuff that has been made by the pharmaceutical companies, so they can get a patent. When we talk about progesterone, we're talking about micronized progesterone, the exact same molecule that your body produces. So with that, let's talk about some of the myths. You want to kick it off?
I mean, probably the biggest is estradiol causes blood clots.
Okay.
I mean, I see that quite a bit. And I think the hard part is the fact that you just spoke of. Everything gets lumped together as one. When people talk about estrogen, they lump the conjugated estrogen, which was Premarin back in the day, and with estradiol, and they're not the same.
Correct.
Oral estradiol does have a better cardioprotective and brain protective mechanism over, say, the transdermal, the cream, or the patches. It is contraindicated in potentially patients who have blood clot history. But if that's really my go-to. And I think the hard part is when patients go to other providers is, unfortunately, we're not taught these things in medical school or in school. When we get
Correct.
taught, we're not taught. We're barely even taught birth control pills, so we're not taught nutrition either. So the issue is what we assume we knew. Things have changed so much over the years. In that WHI trial, the big study that gave the negative nod to hormones and kind of ruined it for generations of females, really did women a disservice.
100%. I think you nailed it. I think we humans, and then when you add in a title because of your education, then you get this confirmational bias, and you're like, it's hard to let go of. And everyone says, everyone knows. Okay, well, what do the studies show? The studies don't show that, but everyone knows. Well, everyone knows the Earth was flat 300 years ago, right? But when we look at the studies, it's not. It's round. So it's a sphere. So yeah, oral estradiol, transdermal estradiol, injectable estradiol, they're all better forms of estrogen replacement than conjugated equine estrogens, in my opinion. But I agree with you. Oral is the way to go, unless for some reason a woman doesn't tolerate or it's contraindicated. Again, the studies don't show that it increased the risk of a blood clot. With my male patients that I put on testosterone that had a blood clot, I tell them, listen, because you've already had a blood clot, you're at a 30% increased risk for having another blood clot, whether or not we do any therapy. And the problem with this is that if I do therapy, another doctor is going to blame the therapy and disregard that you are already at a higher propensity for having the blood clot. So, we have that discussion, and I have them sign, something that says they understand that, and then they want to continue on with treatment. It's just that simple. you said something and I was like, oh, that's important. And then my brain went,
Maybe we need some more estradiol.
I probably do need a little estradiol, right? One of the things I pulled up was that article that was shared with us, and it was now from 2009, but it was, you think, man, that was 16 years ago, right?
All the articles, not all, many of the articles that are presented at our conferences over and over again, we've been seeing the same articles for how many years? And
Yeah.
yet these are the same articles that are being represented to the FDA to try to get, this stuff has been around forever,
Yeah,
and
we've
just, it's
known.
frustrating part of people just turn a blind eye to it, which is,
Yeah, and the study. So this one was called Hormone Replacement Therapy and Cardiovascular Disease Revisited, and I was just kind of going back through that, and there's a wealth of biological evidence that estrogen has beneficial effects, supporting a large body of epidemiological evidence demonstrating reduction in coronary events with HRT. And it was like, the preliminary WHI results did not reflect accurately true benefits and risks, and HRT should remain a potential preventive treatment for coronary heart disease. There was a part in here I read, basically, that we see women with issues with coronary artery disease and heart attack. And when I worked in the ER, they come in chronologically older than the men because they've had that protective effect of the estrogens. And that may be changing because of the amount of women on birth control, because that takes away that protective effect. And then, with the obesity epidemic of, is it 50% hypertensive, 50% obese, 50% pre-diabetic or diabetic? It's like, we're just screaming to have more and more heart disease is a population. But I thought this was interesting. In addition, a post hoc study of coronary artery calcification scores in women showed a significant decrease in those previously assigned to estrogen. So in that, just saying in estrogen, that's what I wanted to say. That if you're not savvy to this world, and you could be a healthcare provider and have read a lot of literature, but in this world, you really have to parse through the literature and know when they're trying to trick you, because they will say estrogen when they mean conjugated equine estrogens. If they use estradiol, I think maybe I've seen one study that used estradiol and referred to it as estrogen, but every other study says estradiol when they use estradiol. Every study will say micronized progesterone when they use micronized progesterone. If they don't, they will call it progestins, right? And so, and it's funny because when you look in the PDR, it says they're the exact same. It's wrong. It's 100% wrong. The studies prove it. So, but the problem is that in North American Menopause Society, NAMS, ACOG, the American College of Gynecologists, and I think even the Endocrine Society, they all look at them like they're the same, which blows my mind until you understand that those societies are getting funded by big pharma. And I don't want to sound like, conspiracy theorists, but you got to wonder, this evidence has been out there for a long time, and there's smart people, right? Myself, Kerry, Dr. Rosier, we're not the only smart ones out there. There's a lot of smart people in those organizations. They got to know better. So I got to think that there's probably something else kind of nefarious called dollars going on there. But that's pretty interesting that, women who had been on even, conjugated equine estrogens.
Well, even the WHI trial, and the arm that was just the conjugating equine estrogen with the testosterone, that arm showed a decrease in the cardiovascular disease. Where they saw the increase was where you had the Premarin, the conjugating equine estrogen, and the progestin.
And after age 60.
Yeah, and that's
that was the thing.
The sample population was just older in general.
Right. I think the average age was about 63, right? Yeah. So,
And at that juncture,
there's a lot of disease.
Postmenopausal for X amount of years already and not had started anything at all, which you're looking at tainted population, unfortunately.
100%. So, and this, that was the next point here, is that thus it appears that HRT may confer benefit for coronary heart disease prevention when initiated below the age of 60 or within 10 years of menopause, and a significant decrease in breast cancer incidence in women on estrogen alone therapy.
Which is why, I mean, it was just why, years ago, and not that long ago, we would truly wait 12 months post last menstrual period to start estrogen. That was kind of the rule of thumb. And I mean, really, this day and age, you're seeing so many women in perimenopause with very, very low estradiol and very symptomatic or not symptomatic. But then you worry about, you've got low estradiol, so we're going to wait for another 6 months
I mean,
12 months,
is there going to be a lot of things developing in that, 6 to 12 months? So just some interesting things. This was another thing in this particular article. It stated, similarly, statins have not been effective in reducing coronary heart disease events in women. Furthermore, the increased risk of breast cancer seen with statins is similar magnitude to that reported with HRT. And that is dropping bombs. but that increased risk of breast cancer was not seen in the estrogen only arm, but in the estrogen progestin. So, and that was medroxyprogesterone acetate. So the fake progestin with the fake conjugated equine estrogen. So, you got to understand how to, interpret these studies and that's what, Kerry and I do. And that's where we go to lectures and conventions that, kind of really parse through the literature and look for those, key words and go, okay, so we can understand exactly what the study was looking at. Because if you don't understand it, to me, it's like, you're saying, well, I'm studying candy. What? There's how many different flavors and what, so you got to know exactly what you're looking at. So what else we talk about? Of more importance, if a woman is taking HRT, it does not need to be stopped on the grounds of her cardiovascular safety when she passes her 60th birthday. That was another dogma that had been taught to us. Well, you only want to be on it for the shortest duration of time. Why? It provides so many health benefits. And so, at the age of 60, we just take you off of it and say, go ahead and get all these diseases. It doesn't make sense. That again, ACOG, NAMS, that was their recommendation. I think they've revisited that now. I think they've changed their position, which would be great. But and I had patients going, well, now that I'm this age, my other doctor says I don't need to keep on this. I'm like, well, we've reduced your risk of heart disease by 50%. When you stop, your risk doubles, right? What? Yeah. So you might want to continue on it. And well, my other doctor said, I'm going to get breast cancer if I keep this up. Well, unfortunately, I think your other doctor was like the other doctor on the commercial that said sugar is sugar. You're not too smart because it didn't read the literature. And again, we still have physicians out there stating this, oncologists stating this, because that's what they were taught. And then these guys say, when it comes to cancer, we walk on water. What we say is gospel. Not if you're not keeping up with the literature, it's not.
Yeah, patients always ask, how long do you think I have to stay on this? And my answer is, what drives patients into our clinic obviously are symptoms, right? Of course they want good health, but what is their driving force is their symptoms that drives them in.
They don't feel good.
I said, listen, even at low dosages, I can get your symptoms controlled, but my job as a provider and Dr. Pierce's job and all of our other providers is to keep you as healthy as you can, and to answer that question, how long do you have to stay on this is how long do you want to stay healthy? How long do you want to continue to feel good? And to me, hormones personally are medically necessary. I will never be without my hormones.
And you shouldn't. When a woman goes into postmenopause or if she's on hormones and you stop them, what happens? Well, those symptoms can come back, but more than that, their lipid profile changes. We've talked about that before with women that never had cholesterol issue in their life. They go into menopause and all of a sudden they got a cholesterol issue. Ooh, here's your statin drug.
Bone density decreases.
Bone density, right? Blood pressure goes up. their glucose tolerance goes down. So
Memory.
yeah,
The
so
list goes on and on.
yeah, just so um, just very interesting, right? Rethinking the common misconception of statins and cardiovascular disease. Yeah, this is a tough one, but right, accumulated data across 6 randomized trials and 11,435 women do not provide strong support for the use of these medications, statins, for primary prevention of coronary heart disease in women. And it doesn't really, help primary prevention in men either.
It's probably one of the number one prescribed
It is, yeah.
medications for primary care.
And this is a review article, postmenopausal hormone therapy in clinical perspective, in the Journal of the North American Menopause Society. So this was in NAMS, right? Final analysis data supported the use of lipid-lowering medications for reduction of coronary heart disease in women on which to base recommendations for primary prevention are limited, meaning no benefit, right? So, hormone replacement will do the trick. And we just have people that, in healthcare and misguiding patients saying, well, no, we need you to be on the statin. We need you to be on the aspirin. We need, so maybe if they've already had a coronary artery or a heart attack, they had some issue. But I mean, it's interesting because before we started filming, we were talking about an observation we made, and without getting into specifics of that, but we've noticed, a handful of men coming back with low estradiol levels, and they're not on an aromatase inhibitor. So what is that, right? And one of them is a patient that he's been a patient in and around this clinic for over 20 years. And we know his history. He's got significant coronary artery disease. And we put him on oral estradiol because we know the protective effects of it, and he's got a low estradiol level. We need to get that turned around. It's not healthy for a man to have a low estrogen level, especially long duration.
I'm just waiting for the cardiologist to call and say, "Why is he on oral estradiol?"
Yeah,
but I know what to say. Show so.
Yeah. So I mean, and that's the thing is, we can back up why we're doing what we're doing with the literature. That doesn't mean somebody's going to want to listen to it, but what else? I'm just trying to think of there's so many misconceptions, but we know it doesn't cause heart disease. We know it improves cardiac outcomes. We know it doesn't cause breast cancer. We know it reduces the risk of breast cancer. Alzheimer's disease, there's more and more studies coming out showing that it reduces the risk for dementia to include Alzheimer's disease.
Across, I mean, those are the main.
Yeah.
Even with progesterone, with progestins, one of the things I would always run into, and I have had patients run into, is going to get their, say if they're on oral birth control pills. I ran into this years ago, where I was on oral birth control, and every time I would go to the counter and get my prescription, I would be getting my birth control and my progesterone, and they wanted to counsel me every time because they your pharmacist used to talk to you. Do you know you're on 2 progesterone? Do you know you're taking double the amount of progesterone? And I want to say, do you not know what you're talking about?
Yeah.
It's so frustrating, and patients get it all the time. And the hard part is, we know the study, we know what we know, but the lay person does not. Yet neither does the pharmacist sometimes, and it's they think that we're crazy, and I have to explain to the patient the difference between progestin and progesterone, where the pharmacist doesn't know what they're talking about either, which is
it's befuddling, right? It's just another one that we get a lot of female patients in, and I'm gaining weight. Well, it's because your estradiol levels are low. Well, I was told that if I take estrogen, it's going to make me get fat, and it's the opposite is true. Generally look at your cohorts when you were younger, you had less body fat in general if you ate well and exercised, and then you haven't changed anything and you just went into menopause and you gained the body fat. I mean, it's pretty clear what's causing this, right?
I think the keywords, collectively those words are your hormones are healthier, and diet and exercise.
Yeah, but and so a lot of these women are still maintaining the diet and exercise because that's what we get. Like I haven't actually, I'm working harder on my diet and exercise, and I'm getting worse, right? And then you go, well, that's easy because that's a slam dunk. And this was like, estrogen has been shown to counteract weight gain and particularly central adiposity. Lower rate of insulin resistance in women on HRT, and the CORA study is in line with the large intervention studies, both of which have documented the effectiveness of HRT to prevent diabetes mellitus, so just regular type 2 diabetes. It's very similar to testosterone doing that, and I got to think that it may end up being that it's the aromatization of testosterone to estradiol in men that is reducing their risk for continuation of insulin resistance to type 2 diabetes. Because it's, the study came out and then basically emphatically said testosterone inhibits, didn't say reduce, it said it inhibits the conversion of insulin resistance to type 2 diabetes. So, maybe if that gets looked at a little deeper, we'll find out that it's estradiol, and yet another reason, to not take aromatase inhibitors. Yeah, it's just funny because we go through and listen, and I'm just looking at this, and, it's like, meta-analysis shows that postmenopausal estrogen is associated with a 35 to 50% reduced risk of coronary artery disease. And again, the meta-analysis is looking at not only estradiol, but conjugated equine estrogen. So that's why it's stated that way. And I can just hear somebody up on stage right now talking, right? So, yeah. What else? Is there anything, to kind of dispel any more myths about estradiol or progesterone?
No, I mean, it's always a challenge when patients go to their other providers, you know what I mean? And I run into that a lot. I mean, I was working with an older nurse practitioner who's since retired when I first came to town. And again, I was on birth control and, progesterone and on testosterone and thyroid. And, she was, telling me I was going to get breast cancer. And the odd thing is you're prescribing me birth control pills,
right?
It's just so fun. It was very humbling to me to experience that, because I hear patients come in, my doctor told me this, and I had never experienced that, and when I went to my provider and they were reading me the Riot Act, the nice thing is I know better and I know what the studies show. The hard part for patients is they don't know, and they put your trust in you, and as well as they put their trust in other providers, and then they have conflicting points of view.
Stark contrast, right?
Yeah.
One on one side, the other. And it's funny because everybody says, well, you guys should know the same stuff. No. It's, just because somebody went to medical school, that gives us a foundation
of many things.
And, like I said, the good book, by Dr. Robert Ludlow, professor at USC, UCLA, the title of the book is The Lies I Taught in Medical School.
Fantastic
right?
book.
It's right. You and I are both reading it. And
I'm still in the beginning stages of it.
Yeah.
I brought it to work so I can read it in between patients because
it's hard to put down, especially as you're a healthcare provider, because you start looking at this stuff and it's the information that we were force fed. And worse, this is the information that the board exams are set on. And so, you have to learn it this way. And that's where the confirmational bias comes in, because you want to pass all the boards. If you give the right answer,
you're going to flunk.
You're going to flunk. Right. Yeah. So that makes it challenging, because you want to believe that education that you got, it's, I didn't go to some high revered pristine university like USC, UCLA. I went to the College of Osteopathic Medicine in the Pacific in Pomona, California. I got a wonderful medical education. I've learned a whole hell of a lot more than I learned in medical school outside of medical school.
Amen.
And it was because I took my own personal interest in integrative wellness. And, I never travel on the path that everybody else is traveling on. So I'm always going against the grain, but it just never made sense to me that we need to give a drug for every condition. And some of the things that this book is saying is like, man, I've been saying that for years. I've been saying that for years, even in medical school. I recall, we had an overweight surgeon giving us a lecture on diet that was all, and he was talking about a parenteral diet when somebody was in the ICU, and it was like 60% carbs and, or 70% carbs and 20% protein and like 10% fat. And I was like, that is terrible. What do you know about this? And he's done. I said, well, with all due respect, sir, look at you and look at me. I think I know a little bit more about diet. And he was offended, and he should have been offended. He should have been offended at himself. But, and it was funny because 2 years later, when I was doing a rotation in a trauma ICU, the literature had come out that, yeah, we need to cut back on the carbs and increase the fat, because they had already tried with the high carbohydrates, really chasing down with the insulin to make sure that the blood sugars, stayed within normal ranges. And then they realized, that was a disaster. Why? Because the higher insulin in the patient was the problem, right? And so it's just crazy, but that was the thought process. And this is, not that long ago. It was the turn of the century, but you'd think that we had learned a lot. And guess what? We still don't know a lot. We're with AI and all of this stuff, we're going to be learning a lot more, a lot faster. But that to me is the beautiful part of medicine. You have to be willing to be dynamic. And if the science that is, what you learn is proven to be wrong, be humble enough, to take a step back and look at the literature and maybe change your practices, right?
Every time we go to a conference, our core office manager, poor Joni, every time we come back for a conference, we're changing something, and it's big, and we're like, okay, we're changing some kind of protocol of the place, and she's like, okay, what do you got? Hit me with what you got. And because, but that's part of medicine. If you're not learning, you're not changing, you're not growing, you're not staying on top of the newest stuff. And that's really what it comes down to.
Yeah, and for us all, all we're trying to do is deliver the best healthcare possible. In the area that we do, but we're taking on bigger and bigger roles, because the more we learn about the metabolic effects of our modern Western carbohydrate sugar laden diets, you're like, why are people doing this? It was interesting to me that if you'd asked me before about the three micronutrients, I'd have said they're all essential, right? But it turns out that we only need to eat protein and fats, and our body will produce all the sugar it needs in the liver. So we don't even need to eat carbohydrates. Like wow. So, I think people take that to the nth degree with some of these diets that are out there, but it's like you can eat proteins and fats and vegetables and some fruits, and I think you're killing it. Mm-hmm. Right? So, boy, do we want to go any further? Or think we've,
came in pretty good.
Yeah.
If you ask me.
All right. I think we can wrap that up then. So thank you for joining us. Hopefully you got a little bit more information on some of the health benefits of estradiol and micronized progesterone. Don't be afraid. Find yourself a good provider who's, well versed in this stuff. If your doctor's not well versed in it, not willing to prescribe what, the right way, or if they're recommending that you do things opposite of what we're talking about, then you can make a different choice. Because remember, your healthcare providers are employed by you. You are the employer, so you can fire them. I tell my patients that all the time. If you don't like what I'm doing, fire me, please. So I'm not offended. So thank you for joining us. Have a wonderful day, and look forward to seeing you for our next podcast. Oh, and I've got coming up for Veterans Day, we've got a big surprise for you folks. If you're a veteran, got a big surprise of a guest I'm bringing in. So look forward to seeing you then.